Welcome to the deep dive. Today, we're plunging into a world that's, well, utterly alien to us. The underwater realm. Humans just aren't built for it.
Not naturally.
But our, insatiable curiosity has driven us to explore the ocean's depths. And that's led to some truly remarkable innovations and a whole fascinating field of medicine dedicated to understanding and overcoming the unique challenges of being submerged.
Exactly. And that's our mission for this deep dive, really.
Uh,
To unpack the core physiological hurdles and potential health issues that divers face.
right.
We'll be drawing heavily from the textbook Hyperbaric Medicine Practice, which gives a really comprehensive overview. And as you probably know, hyperbaric medicine using pressurized oxygen and diving medicine are very closely linked.
Oh, so.
Well, not least because hyperbaric chambers are the primary treatment for a lot of diving-related injuries.
Okay. And it's interesting, it's not just hardcore professionals anymore, is it? Recreational diving is, well, it's booming.
It really is. And the advanced gear that used to be just for military or commercial divers, it's increasingly accessible to everyone.
So that blurring of the lines makes understanding these medical aspects much more important for a wider audience, right?
Absolutely crucial.
Okay, let's unpack this then. What's our roadmap? Where are we going in this underwater world of medicine?
Okay, so first we'll start with the fundamental physics. The gas laws. They really lay the groundwork for understanding, well, pretty much everything that happens to the body underwater.
Right.
Then we'll look at the different types of underwater breathing apparatus, the gear that lets us go there.
SCUBA and the surface applied stuff.
Exactly. From there, we'll delve into the effects of breathing, abnormal gases at pressure. That brings its own set of risks.
Yeah, I can imagine.
And naturally, we have to cover the various diving-related injuries, DCS, barotrauma, that kind of thing.
The bends and squeezes.
Precisely. And finally, we'll touch on specific considerations for certain groups like pregnant women, older divers, and also look at the long-term effects and using medications while diving.
Sounds like a thorough exploration. So let's start right at the beginning. Diving physics. What are the essential laws we need to get our heads around?
Okay, there are three fundamental gas laws that are just absolutely crucial. Boyle's law, Dalton's law, and Henry's law.
Okay.
Think of them as the basic rules governing what happens to gases and therefore to us underwater.
Okay, Boyle's law. That rings a bell from school. Quick refresher.
Sure. So Robert Boyle described this inverse relationship between the pressure and the volume of a gas, assuming the temperature stays the same.
Inverse. So pressure goes up, volume goes down.
Exactly. Squeeze a gas, increase the pressure, its volume shrinks proportionally. Let it expand, decrease the pressure, volume increases. Simple example. Double the absolute pressure, the volume gets cut in half.
Right, like taking a balloon down 33 feet underwater where the pressure roughly doubles. Volume halves. Makes sense. But how does that cause problems for divers?
Well, this is directly responsible for barotrauma. That's tissue damage from pressure differences between gas-filled spaces in our body, ears, sinuses, lungs, and the water outside.
If you can't equalize.
Exactly. If the pressure inside can't match the outside pressure, the volume changes cause damage. It's also behind pulmonary overinflation syndromes, lung injuries from air expanding too fast on ascent,
Ouch.
and squeeze injuries, where pressure compresses air spaces if equalization fails. Plus, Boyle's law affects how fast we use air. Denser air at depth means we consume more per breath. And it's key for surface-supplied diving systems, too.
Okay, and you mentioned something interesting earlier. The risk of barotrauma is actually greatest near the surface. Why is that? It seems counterintuitive.
It does, doesn't it? But Boyle's law tells us that for any given change in depth, say 10 feet, the relative change in volume is much larger when you're closer to the surface.
Okay, explain that.
Think about it. Going from the surface, 1 atmosphere absolute, or ATA, down to 33 feet, which is 2 ATA. You've doubled the pressure. The volume halves. That's a 50% reduction.
Right. Big change.
Now, go from 33 feet, 2 ATA, down to 66 feet, 3 ATA. The pressure only increased by 50% this time, and the volume reduces by only a third relative to the volume at 33 feet. It's a smaller proportional change than that first 33 feet.
Ah, okay. So those first few feet up or down are where the biggest percentage volume shifts happen.
Exactly. So even small depth changes near the surface demand really careful equalization. That's a key takeaway.
That's a really important practical point. All right, next up, Dalton's law. Who was Dalton and what's his big contribution here?
John Dalton, English chemist. His law of partial pressures says that in a mix of gases that don't react with each other, like air,
Nitrogen, oxygen mostly.
Right. The total pressure of the mix is just the sum of the individual pressures each gas would exert if it were alone in that space. We call those individual pressures partial pressures.
Okay, and how do we figure out the partial pressure?
Simple formula. Partial pressure, or PP, equals the total absolute pressure, ATA, times the percentage of that specific gas in the mixture.
So at the surface, 1 ATA airs about 21% oxygen, 79% nitrogen. So oxygen's partial pressure is 0.21 ATA, nitrogen's about 0.79 ATA-ish.
Pretty much, yeah. Now, what happens when we go deeper?
Total pressure increases, so the partial pressures must increase too.
Exactly. They increase proportionally. And here's the kicker for divers. Gases that are totally harmless at their normal surface, partial pressures can become toxic at the higher partial pressures you encounter at depth.
Okay, so Dalton's law is key for understanding things like oxygen toxicity and nitrogen narcosis.
Precisely. We'll get into those specifics later, but Dalton's law is the foundation for understanding why they happen.
Got it. Okay, third one, Henry's law, William Henry.
Another English chemist, yes.
Right.
Henry focused on how much gas dissolves into a liquid. His law states that at a constant temperature, the amount of a gas that dissolves in liquid is directly proportional to the partial pressure of that gas sitting above or in equilibrium with the liquid.
Okay, connecting that to diving. We're breathing air under higher pressure, higher partial pressures of nitrogen and oxygen. Our bodies are mostly liquid.
Yeah, you got it. As you go deeper and breathe air at higher partial pressures, more of those gases, especially the inert nitrogen and air, dissolve into your blood and tissues.
Like CO2 dissolving in a soda bottle under pressure.
Good analogy. The deeper you go, the longer you stay, the more gas dissolves. We call that the gas load.
Okay, and flip side. Coming up.
Right. As you ascend, the surrounding pressure decreases. The partial pressures in your lungs drop. So the dissolved gases in your tissues start to come out of solution.
Back into gas form.
Yes. And Henry's law explains why a slow, controlled ascent is absolutely critical. If you come up too fast, those gases come out of solution too quickly, forming bubbles in your tissues and bloodstream.
That's decompression sickness. The bends.
That's exactly it. So Henry's law is fundamental for understanding DCS and also for how dive tables and dive computers work. They're all about managing that gas coming out of solution safely during ascent.
Okay, so Boyle, volume changes. Dalton, individual gas effects at pressure. Henry, gas dissolving in tissues and the risk coming up. That clarifies things a lot.
They really are the cornerstones.
Right. Now that we've got the physics basics, let's talk about the GU, the breathing apparatus that lets us actually survive down there. What are the main types?
We can broadly split them into two main categories. Self-contained underwater breathing apparatus, that's SCUBA.
The one most people picture.
Right. And surface-supplied underwater breathing apparatus.
Okay, let's start with SCUBA. What are the key parts?
So SCUBA means the diver carries their own gas supply. Two main flavors, open circuit and closed circuit. Open circuit is what you usually see. You've got air cylinders, a valve, a manifold maybe, and crucially, a demand regulator.
The regulator, that's the thing you breathe through.
Yes. It's usually a two-stage system. It takes the really high pressure in the tank, maybe 3,000 psi, and knocks it down to a pressure the diver can actually breathe. The second stage, the part in your mouth, delivers air at the surrounding water pressure when you inhale.
And the exhaled air.
Just gets vented out into the water, creates all those bubbles. That's open circuit.
Okay, and closed circuit. That sounds different. More advanced?
It is more complex, yeah. Closed circuit SCUBA are often called rebreathers. Instead of venting your exhaled breath, they recycle it.
Recycle it. How?
Typically, they use a small tank of 100% oxygen feeding into a flexible breathing bag like counterlungs. When you exhale, the gas goes through a chemical scrubber that removes the carbon dioxide.
Takes out the waste product.
Exactly. The remaining oxygen, maybe topped up with a bit more, gets recirculated back to the diver. Much more gas efficient.
And no bubbles, right? You mentioned that.
Correct. No bubbles, which is why they're favored for things like military special ops or certain scientific work where you don't want to disturb marine life or, be conspicuous.
Very cool. James Bond stuff.
Kind of.
Okay, what about the other category? Surface-supplied systems. Who uses those?
Surface-supplied UBA is more common in commercial and military diving. Big jobs. The key difference is the breathing gas comes from the surface through a long hose and umbilical.
Unlimited air supply, basically.
Pretty much, yeah. That's the huge advantage for long or very deep dives. Gas comes from a compressor, often with backup high-pressure tanks on the surface. It has to be delivered at enough pressure to overcome the water pressure at depth, plus any loss in the hose itself.
Makes sense. Any other benefits?
Communication is a big one.
Yeah.
Usually there's a comms cable built into the umbilical for voice chat with the surface team.
Very useful.
Definitely. And if that fails, there are standard line pull signals too. but the downside is obvious.
The umbilical itself.
Yeah. It can get tangled or snagged on things underwater.
Right.
That's the main hazard.
Right. So different systems for different needs. Okay, let's shift gears to something that sounds, well, inherently problematic. Abnormal gases. Breathing normal air is fine up here, but diving means higher pressures, sometimes different gas mixes. What are the risks?
Yeah, diving definitely introduces situations with abnormal gas levels or types that can cause unique stresses and potential health problems. We should cover hypoxia, hypercapnia, nitrogen narcosis, carbon monoxide, hyperventilation, oxygen toxicity, and high-pressure neurological syndrome. Quite a list.
Okay, first one. Hypoxia. That's just lack of oxygen, right? Simple but dangerous. How does it happen underwater?
Exactly. Hypoxia is not enough oxygen getting to the tissues.
Is that right?
In diving, it can happen if the gas supply gets interrupted, if you run out of gas completely,
The worst nightmare.
or if the gas gets contaminated with something else that displaces the oxygen. Symptoms usually kick in when the partial pressure of oxygen, the PO2, drops below about 0.16 ATA.
What are the signs?
It can be rapid and scary.
Yeah.
Sometimes the first sign is just unresponsiveness. But other things include trouble concentrating, losing coordination, muscle control issues, feeling really drowsy or weak, maybe agitation, or even, weirdly, euphoria.
Euphoria from lack of oxygen. That's odd.
It seems counterintuitive, but it happens. Shows why you need to know all the potential signs. Treatment is obvious. Get oxygen back. Underwater, that means switching to a bailout bottle or alternate source. On the surface, 100% oxygen immediately.
Okay, next. Hypercapnia. Too much carbon dioxide. CO2 toxicity. What are the dangers there?
Hypercapnia, excess CO2 in the bloodstream, like hypoxia, suddenly passing out can be the first sign.
Scary.
Very. Other symptoms: headache, dizziness, shortness of breath, feeling like you can't work as hard, rapid pulse, maybe burning eyes, confusion, leading up to unconsciousness.
In the treatment?
You need to either reduce the CO2 in the gas being breathed or improve the diver's ability to exhale it, effectively increase their alveolar ventilation. That might mean, increasing airflow in a helmet, getting the diver to reduce exertion, switching gas supplies, or ending the dive if it's an equipment issue.
What causes CO2 to build up like that during a dive?
Two main ways, really. Either there's too much CO2 in the gas coming in.
Like contamination. Or a rebreather scrubber failing.
Exactly. Or the diver can't get the CO2 out effectively. Their alveolar ventilation is decreased. This can happen because the breathing gas gets really dense at depth, making it physically harder work to breathe.
More effort just to move the air.
Right, both through the gear and their own airways. Other things can contribute too. Sometimes high oxygen levels can slightly suppress the drive to breathe. The physical work of diving produces more CO2. And sometimes novice divers might underbreathe or hold their breath to save air.
Bad idea.
Very bad. And importantly, hypercapnia makes other problems worse. It can increase nitrogen narcosis, raise the risk of DCS, and make oxygen toxicity more likely. So managing CO2 is critical.
Absolutely. Okay, let's talk about nitrogen narcosis. You mentioned it was recognized way back. What exactly is it? Sound narcotic.
It is. Nitrogen narcosis is basically a reversible state of altered mental function. It's caused by the anesthetic effect of breathing inert gases, mainly the nitrogen in air at increased partial pressures.
So it's the nitrogen itself having an effect at depth.
Yes. It was first described back in 1826 by a French physiologist, Junot, who used a diving bell and felt the effects himself. Divers usually start noticing it around 100 feet or so, and it gets stronger the deeper you go or the faster you descend.
What does it feel like? Is it like being drunk?
That's the classic comparison, yeah. Symptoms include impaired judgment, maybe feeling euphoric or overly confident, not worrying enough about safety.
Dangerous combination.
Definitely. Maybe acting silly, laughing inappropriately. Some people feel numbness or tingling, especially lips, gums, legs. The main impact seems to be on thinking, decision-making, rather than, say, physical coordination.
And the fix?
Simple. Come up shallower. Reducing the depth reduces the partial pressure of nitrogen, and the narcosis lifts pretty much immediately.
Can you get used to it?
Some divers report developing a tolerance, or learning to manage it by focusing very deliberately. But things like being tired, having high CO2, being cold, or descending too fast can make you more susceptible.
And for really deep dives.
They often switch gas mixes, replacing some or all the nitrogen with helium. Helium has much less narcotic effect at pressure.
Interesting. And what's happening physiologically? Why does nitrogen do this?
The exact mechanism is probably multifactorial, complex. The classic theory is the Meyer-Overton hypothesis. The more soluble a gas is in lipids or fats, the more narcotic it is.
Nitrogen dissolves in fat.
Yes, it's quite lipid-soluble. So the idea is it dissolves into the fatty membranes of nerve cells, maybe makes them swell slightly, and disrupts how signals pass between neurons.
Okay.
There's also growing evidence that inert gas molecules might bind directly to specific water-repelling pockets in proteins within the nervous system, things like ion channels or neurotransmitter receptors, and mess with their function that way. Understanding that lipid solubility helps explain why helium is used deeper. It's much less soluble, less narcotic.
Fascinating. Okay, next gas problem, carbon monoxide. We know it's bad news. How does it get into a diver's air supply?
Carbon monoxide, CO, comes from incomplete combustion. Think engine exhaust, fires, even tobacco smoke. If the intake for the compressor-filling dive tanks is too close to an exhaust pipe, for example.
Contaminated air gets pumped into the tank.
Exactly. And it's dangerous. Even low levels can cause headache, nausea, vomiting. Higher levels lead to mental status changes, neurological problems, passing out.
And the mechanism. How does it harm us?
CO binds to hemoglobin, the oxygen-carrying protein in red blood cells, incredibly strongly, much more strongly than oxygen does. It forms carboxyhemoglobin.
Taking up the spots oxygen needs.
Right. It reduces the blood's oxygen-carrying capacity. Plus, the CO that is bound makes the hemoglobin hold on to the remaining oxygen more tightly, so less gets released to the tissues where it's needed. It causes hypoxia, essentially.
And you mentioned symptoms might not show up right away underwater.
Correct. Because you're breathing oxygen at a higher partial pressure at depth, that can sometimes compensate a bit, mask the effects of the CO while you're down.
Delaying the onset.
Often, yeah. The symptoms become much more obvious during ascent, or once you're back on the surface and that extra oxygen pressure is gone. Treatment is immediate. Get away from the source, give 100% oxygen for mild cases. Severe CO poisoning needs hyperbaric oxygen treatment.
Okay. Moving on. Hyperventilation. People sometimes do this deliberately, right? Like before breath hold dive.
They do, but it's generally a bad idea, especially in diving. Hyperventilation usually happens unintentionally in diving, often due to anxiety, especially with new divers. It means breathing faster and deeper than your body actually needs to.
And what does that do?
It blows off too much carbon dioxide, lowers the CO2 level in your blood. This can cause dizziness, tingling or twitching in hands and feet, even muscle spasms in hands and feet. That's called carpopidal spasm.
That sounds like it could be confusing underwater, maybe mistaken for something else.
It can be, yeah, sometimes confused with oxygen toxicity symptoms. But those hand and foot spasms are a key clue for hyperventilation. The fix is simple. Consciously slow your breathing down, take deeper, less frequent breaths. Reassurance helps too if it's anxiety-driven.
Okay, so we've had too little oxygen, too little CO2. Now, too much oxygen. Oxygen toxicity. How can the stuff we need to live be toxic?
It seems odd, doesn't it?
Yeah.
But yeah, breathing oxygen at partial pressure significantly higher than normal for too long can overwhelm the body's natural antioxidant defenses. This leads to a buildup of reactive oxygen species, ROS, which damage cells.
And in diving, this happens with deeper dives or special gas mixes.
Exactly. Deeper dives increase the partial pressure of the oxygen in regular air. Or using nitrox mixes, which have more than 21% oxygen, or pure oxygen in rebreathers. These increase your oxygen exposure.
What are the main types of oxygen toxicity?
We usually talk about three main targets: central nervous system, or CNS toxicity, pulmonary or lung toxicity, and ocular or eye toxicity. The basic treatment for all of them is to reduce the exposure to high-pressure oxygen.
Let's start with CNS toxicity. You said that's the biggest wreck for an in-water emergency. Why?
Because the most severe symptom is a seizure. And having a seizure underwater is obviously incredibly dangerous, likely leads to drowning.
Yeah. What triggers it?
The main factor is breathing oxygen at a high partial pressure for too long. But other things can lower the threshold, make it happen sooner or at a lower PO2. Things like inert gas being present, high CO2 levels, just being immersed in water versus dry, darkness, and increased metabolic rate from exercise, cold, or even just stress activating the sympathetic nervous system.
Are there warning signs before a seizure?
There can be. There's a mnemonic often used, VNNDS. V for vision changes tunnel vision, blurriness. E for ears, tinnitus, ringing. N for nausea. T for twitching, especially facial muscles, lips, eyes, maybe limbs. I for irritability or mood changes. D for dizziness. And C for convulsions, the seizure itself.
VENEDC, okay.
And interestingly, there's research happening now on wearable tech, like watches, that might detect physiological changes before a seizure hits, giving a diver a warning.
Wow, that would be huge for safety.
Potentially, yes.
Okay, what about the lungs? How does too much oxygen hurt them?
Pulmonary oxygen toxicity usually comes from longer exposures to more moderate oxygen partial pressures, say below 1.5 ATA. It's basically an inflammatory response in the lungs.
Inflammation leads to damage.
Yeah, fluid can build up edema. It can damage the barrier between the air sacs, the alveoli, and the capillaries. Symptoms can include a throat tickle, hoarseness, a burning feeling when you breathe in, cough, chest tightness, shortness of breath. Lung function tests might or might not show a decrease.
Is everyone affected the same way?
No, there's a lot of individual variation and susceptibility and how quickly symptoms appear. They can show up within hours or be delayed up to 3 days after the exposure ends. Usually symptoms resolve when you stop breathing the high oxygen, but very severe or prolonged exposure could potentially cause permanent lung damage.
And the eyes. How does oxygen affect vision?
Several ways. Very high PO2 can cause a temporary loss of peripheral vision that's neuritis. Really long-term hyperbaric therapy, not usually diving, has been linked to cataracts. More relevant to some diving scenarios is hyperoxic myopia becoming more nearsighted.
Nearsighted from oxygen.
Yeah, it seems to change the refractive index of the eye's lens. It's usually temporary, reversible after exposure stops, and more common in people who already have age-related farsightedness, presbyopia.
Anything else eye-related?
Retinopathy of prematurity affects preemie babies on oxygen, not divers. But it's important to remember not all vision changes after a dive are oxygen toxicity. Could just be eye strain or dry eyes from a full face mask.
Right, good point. Okay, so oxygen needs careful management. The last abnormal gas condition was high-pressure neurological syndrome, HPNS. Sounds very specific.
It is. HPNS typically only happens during very deep, long dives, usually saturation dives. We're talking pressures above 15 atmospheres, roughly 490 feet deep, where divers live under pressure for days or weeks.
And breathing special gas mixes.
Often helium-based mixes, to avoid nitrogen narcosis at those depths. HPNS symptoms show a hyperexcitable nervous system. Tremors, often called helium tremors.
Okay.
Involuntary muscle jerks, feeling really fatigued, balance problems, nausea, dizziness, drowsiness, even convulsions in severe cases.
What makes it worse?
How fast you compress the diver down to that depth, and the final depth itself. Faster compression to deeper depths tends to worsen HPNS.
So how do you manage or prevent it?
Mainly by very slow compression rates, including stops at intermediate depths to let the body adapt. Sometimes adding a small amount of nitrogen or even hydrogen back into the helium mix can help counteract the pressure effects.
Does everyone get it?
No, there's significant individual variation. So selecting divers who are less susceptible is one strategy. Plus, those slow compressions, adaptation stops, and giving divers time to acclimatize at the target depth before they start working hard.
Incredible. The challenges at those depths are just immense. Okay, we've covered gases, we breathe from tanks. Let's switch to breath hold diving. Seems so basic, just holding your breath. But what are the key medical points there?
Yeah, breath hold diving or free diving seems simple but has its own unique physiology and risks. The absolute limit is how much oxygen you can store in one breath.
Finite supply.
Totally. While you're down, your body uses oxygen, produces CO2. It's that rising CO2 that triggers the urge to breathe the hypercapnic respiratory drive.
So what's the danger in trying to push past that urge? People hyperventilate first, right?
Yes, and that's incredibly dangerous. Hyperventilating before a breath hold dive blows off CO2, artificially lowering it. This does delay the urge to breathe, letting you stay down longer, but, and this is critical extent, hyperventilating doesn't significantly increase the oxygen stored in your body. So your brain's oxygen level can drop dangerously low, causing hypoxia, before you feel that strong urge to breathe.
Leading to blackout.
Exactly. Loss of consciousness, often near the surface on ascent, which is why it's sometimes called shallow water blackout, dramatically increases the drowning risk.
That's terrifying. What else happens physiologically during a breath hold dive? Pressure increases.
Right. As you descend, the pressure squeezes your lungs, reducing their volume. Interestingly, this concentrates the oxygen in the remaining air, increases its partial pressure, which can actually help you utilize it more effectively initially.
A slight benefit on the way down?
Maybe. But on ascent, as pressure drops and lungs expand, the oxygen partial pressure plummets. PO2 can drop very fast, again risking hypoxia and blackout.
Okay. Any other factors?
Your metabolic rate usually goes up when you hit the water, cold, hydrostatic pressure, so you burn oxygen faster, shortening your safe time. And if air gets trapped during ascent, the expansion can cause lung overdistension injuries, pneumothorax, AGE, just like with SCUBA problems.
Wow. Okay, you also mentioned major cardiovascular effects. What happens to the heart and blood vessels?
There's a powerful set of reflexes called the diving reflex. Key parts are diving bradycardia, a significant slowing of the heart rate triggered by the vagus nerve.
Heart slows down.
Yep. And peripheral vasoconstriction, blood vessels in your limbs narrow, shunting blood and oxygen towards the brain and heart, the vital organs. Helps conserve oxygen.
Smart system.
It is, but that vasoconstriction means tissues in the periphery might go anaerobic, building up lactic acid. Also, arrhythmias, irregular heartbeats are pretty common.
Why?
Combination of factors. That strong vagal nerve activity slowing the heart getting stretched by blood shifting to the chest due to pressure, cold water on the face stimulating nerves, maybe even some ischemia from the high blood pressure.
High blood pressure, too.
Yes, blood pressure often spikes significantly during breath hold dives, especially in elite divers. Systolic can go really high. This is a risk for anyone with pre-existing hypertension.
And you mentioned DAN data earlier. Cardiac issues are a big deal in diving deaths.
They are. Second leading cause in recreational diving, especially over 40s, with hypertension or heart disease. Highlights why cardiac assessment is important, maybe stress tests for older divers with risk factors.
So even breath holding puts huge stress on the heart, and neurologically, the main risk is just passing out from lack of oxygen or too much CO2.
Primarily, yes. Hypoxemia, or severe hypercapnia, leads to unconsciousness, which underwater exponentially increases the risk of drowning. And like we said, because freedivers often do lots of rapid up and down cycles, especially in shallower water training, their ears and sinuses are very prone to barotrauma from those frequent pressure changes.
Really drives home the risks inherent in all diving. Which brings us to drowning itself, a critical topic.
Absolutely. Drowning is a huge global problem. Thousands of preventable deaths yearly in the U.S. alone. Alcohol is often involved, sadly.
And trying to rescue someone.
Can be incredibly dangerous. A panicking victim can easily pull a rescuer under. In SCUBA, drowning is less common if procedures are followed, but it still happens. Entanglement, running out of air, bad gas mix, cave diving incidents.
And the hyperventilation link for breath hold divers.
Strong evidence there. Hyperventilating dramatically increases drowning risk by pushing the breath hold breaking point beyond the point where oxygen levels become critically low.
Okay, there's a common idea that drowning is about lungs filling with water. Is that right?
It's part of the picture, but not the primary cause of death. Drowning death is primarily due to hypoxemia, lack of oxygen to the brain and vital organs. Passing out from lack of oxygen while submerged is the lethal event.
But water aspiration does happen?
Yes, and it's a major factor in complications for near-drowning survivors. It causes lung injury.
Does it matter if it's saltwater or freshwater?
It has slightly different effects.
Yeah.
Saltwater is hyperosmotic, saltier than body fluids. It draws fluid from the blood into the air sacs, the alveoli, worsens oxygenation.
Okay, freshwater.
Freshwater is hyposmotic, less salty. It tends to wash away surfactant, the substance lining the alveoli that keeps them open. This leads to alveolar collapse, again, poor oxygenation. Freshwater can also cause some hemodilution and electrolyte shifts, but the lung effects are usually more critical.
So either way, aspiration messes up oxygen exchange badly. What other complications can near-drowning survivors face?
Respiratory problems are common. Pulmonary edema, fluid in lungs, ARDS, acute respiratory distress syndrome, a severe lung injury, often needing ventilation with PEEP to keep airways open. Pneumonia is also frequent from aspiration, shows up as patches on X-ray.
Do they always need antibiotics?
Generally not right away if it was clean water, unless signs of infection appear later. Many post-drowning infections are actually picked up in the hospital. Systemically, you can see lactic acidosis from the initial hypoxia hypercapnia. Its severity can predict kidney problems. Also hemoglobin in urine, blood clotting issues, DIC, kidney injury, ATN, protein in urine, muscle breakdown, rhabdomyolysis.
And cardiac issues, again, especially in older male SCUBA divers.
Yes, if they have cardiac arrest underwater, it's often heart-related, worsened by the diving stress. CPR response can be okay. The common rhythm seen is often sinus tachycardia, fast heart rate, secondary to the hypoxia and acidosis.
When does someone need hospital admission after near drowning?
If they have significant breathing problems, abnormal chest X-ray or blood gases, or need oxygen or ventilation, lung damage usually shows up within hours. If someone's totally asymptomatic after observation, they might be discharged.
And the long-term outlook.
Depends heavily on how long they were without oxygen and submerged. Over 5 minutes submersion is generally a poor sign. But arriving at the ER neurologically intact is very positive. Lungs can recover in a couple of days. Prognosis is often good for divers who had cardiac arrest, but but responded well to initial CPR.
Okay, very serious stuff. Let's
Yeah.
move to two other potentially deadly conditions: decompression sickness, DCS, and arterial gas embolism, AGE. Every diver's nightmare.
Absolutely. Two of the most serious injuries. DCS, the bends, is caused by bubbles forming from excess dissolved inert gas nitrogen, usually when the surrounding pressure drops too fast on ascent.
Henry's Law again.
Exactly. Gas dissolves in tissues during time at pressure. Longer, deeper dives mean more dissolved gas. Controlled ascent lets you off gas slowly via the lungs. Too fast. Bubbles form.
What do the bubbles do?
Damage in several ways.
Yeah.
Mechanical compression of tissues, damage to the endothelium, the lining of blood vessels, causing leaks, swelling, impaired flow, and they trigger an inflammatory response.
How is DCS classified?
Often using the Golden classification from 1960, type 1 is generally less severe. Musculoskeletal pain, joints, skin manifestations, rashes, itching, lymphatic swelling. Type 2 is more serious, involving the nervous system, lungs, or inner ear vestibular system. Recompression in a hyperbaric chamber. Increased pressure shrinks bubbles, helps gas redissolve for safer elimination. Type 1 might sometimes resolve on its own, but type 2 is an emergency needing urgent treatment to prevent long-term problems like numbness, weakness, paralysis, vision issues, confusion, breathing problems, vertigo, hearing loss. Potentially devastating.
Okay, now arterial gas embolism, AGE, how's that different?
AG is usually caused by lung overexpansion injury, pulmonary barotrauma during a rapid ascent. Boyle's law in action. Expanding gas ruptures, alveoli.
This can happen even on shallow dives?
Yes. It's not strictly time depth dependent like DCS. If alveoli rupture, air can get into the pulmonary blood vessels, travel to the left side of the heart, and then get pumped out into the arterial circulation systemically.
And lodge somewhere.
Exactly. Bubbles block arteries. Where they lodge determines symptoms. Brain, stroke symptoms. Heart attack symptoms.
Very serious. Treatment.
Immediate 100% oxygen and urgent recompression, just like severe DCS. Prompt treatment gives the best chance of full recovery, though some neurological issues can remain.
How can you tell AGE from neurological DCS quickly? They sound similar.
The timing is the biggest clue, usually.
Yeah.
Neurological symptoms hitting very fast, typically within 10 minutes of surfacing, strongly suggests AG. Neurological DCS symptoms often have a slower onset after 10 minutes, sometimes hours later.
But not always clear-cut.
No, there could be delayed onset AG too. So, bottom line, any significant neurological symptoms after a dive need urgent medical attention, regardless of the exact timing.
Crucial advice. Okay, that covers DCS and AGE. Let's broaden out to barotrauma again. We talked about lung issues, POIS. What other parts of the body are prone to pressure injury?
Remember the Graven mnemonic for conditions needed for barotrauma. Gas-filled space, rigid walls, ambient pressure change, vascular lining, and closed space. Any body part meeting those criteria is potentially vulnerable.
Right. So lungs covered under poias pneumothorax, mediastinal and subcutaneous emphysema, AGE. What about elsewhere?
Okay, non-pulmonary barotrauma. External ear squeeze. Happens if the outer ear canal is blocked. Wax, infection, bony growths, surface ear, even tight hoods or earplugs. Prevents water pressure from equalizing.
Symptoms.
Ear pain on descent, maybe hearing loss, bleeding in the canal. Stop descending, try to clear the blockage, ascend if needed, treat any infection.
Middle ear barotrauma, MEB. You said that's the most common.
By far, the middle ear is that GIE space, equalized via the eustachian tube. If that tube's blocked cold, allergies, swollen tonsils, deviated septum, you can't equalize on descent.
Pain again.
Starts with pain. Continued descent, maybe temporary conductive hearing loss, vertigo, tinnitus, severe cases, eardrum can rupture. Intense pain, then relief, maybe blood in the mask.
Treatment. Prevention.
Stop diving till healed. Watch for infection. Ruptured eardrum usually heals itself in weeks, but needs to be fully healed before diving again. Prevention is key. Ascend slowly. Equalize, Valsalva, every foot or two. Check you can equalize on the surface before the dive. Don't dive if you can't clear your ears. Decongestants might help sometimes, but have their own issues we discussed.
What about reverse squeeze on ascent?
Same idea, but air trapped inside extends. Eustachian tube still blocked, usually just ear pain, but TM rupture, vertigo, even facial nerve palsy can happen.
Facial palsy from ear pressure.
Facial baroparesis, yeah. Pressure in the middle ear affects a branch of the facial nerve, CN7. Usually resolves quickly once pressure equalizes. Need to distinguish it from age. Age has other neurosigns, doesn't improve fast. There's also middle ear oxygen absorption syndrome, Drager ear. After dives with high oxygen gas, the O2 gets absorbed from the middle ear, creates negative pressure, feels like a squeeze. Treat with Valsalva.
Okay. Inner ear barotrauma, IEBT. That sounds delicate.
It is.
Yeah.
Pressure changes affecting the inner ear membranes, oval window, round window, cochlear membranes can cause leaks, parallel fistula, tears, or bleeding inside. Risk factors similar to emic, forceful valsalva, can contribute by increasing intracranial pressure.
Symptoms.
Sensorineural hearing loss, tinnitus, vertigo, dizziness, nausea can happen on descent or ascent. Diagnosis needs tests, hearing tests, fistula tests, maybe CT, sometimes surgery. Treatment often starts conservative rest, hope it heals. Surgery is severe or worsening.
How do you tell IEB from inner ear DCS? Symptoms sound similar.
Tricky.
Yeah.
History helps. ME signs point towards IEBT. Some studies suggest dizziness is more common in IEDCS, tinnitus hearing loss in IEBT, maybe due to the different mechanisms, bubble embolism versus pressure effects. If unsure, a trial of hyperbaric oxygen won't hurt, even if it is IEBT.
Okay. Sinuses.
Sinus barotrauma, sinus squeeze, or reverse squeeze. Sinuses meet grave criteria. Risk factors, sinus issues, allergies, surgery history, main symptom, sinus pain, nosebleeds common, treatment depends on the cause. Barodontalgia, tooth squeeze. Gas trapped under fillings, indicate pockets, pain on descent or ascent. Extreme cases, tooth can fracture, needs dental follow-up.
Mask squeeze.
Forget to exhale into your mask as you descend. Create suction, bruising around the eyes, bloodshot eyes, subconjunctival hemorrhage. Looks nasty, but usually harmless. Just needs time.
Skin squeeze.
Air trapped under a dry suit fold, maybe. Creates a suction bruise. Again, time heals it.
Thoracic squeeze.
Mainly in very deep breath hold diving. Negative pressure in the chest causes edema, hemorrhage. Can be very serious shortness of breath, coughing blood, collapse. Needs supportive care.
VI tract.
Gastrointestinal barotrauma. Swallow air or gas from digestion expands on ascent. Usually just discomfort, burping. Rare, but bowel rupture can happen. Severe pain, shock, needs surgery. Mild symptoms. Try descending slightly to vent.
Wow. Pressure affects just about everything within airspace. Let's talk about specific populations, pregnancy and diving. What's the advice?
It's a tough area to study ethically in humans, mostly retrospective data, but the consensus is pretty clear. Diving during pregnancy poses significant potential risks to the fetus.
Why is that?
Fetal circulation is different. It bypasses the lungs. So any bubbles forming in the mother's blood could potentially cross the placenta and go straight to the fetus's brain or heart.
That sounds really bad.
It is. Sheep studies showed fetal sheep were harmed by bubbles, arrhythmias, malformations, death, even when the mother sheep showed no DCS signs. Also, the fetus is naturally in a low oxygen state. Maternal diving increases fetal oxygen exposure, risking oxygen toxicity.
And if the mother needed hyperbaric treatment for a dive accident?
That would increase fetal oxygen exposure even more. There are also survey studies suggesting higher rates of low birth weight, birth defects, neonatal problems in babies whose mothers dive while pregnant compared to those who stopped.
Any other factors?
Vasoconstriction in the mother from cold, exertion, anxiety might reduce blood flow to the uterus. Pregnancy changes body composition, maybe affecting nitrogen uptake release. Standard tables might not apply. Fluid retention can worsen sinus squeeze risk, and morning sickness at pressure. Risk of aspiration.
So the bottom line is?
The risk to reward just doesn't seem favorable. Despite anecdotes of women diving without apparent harm, the potential risks are serious. The general recommendation is to avoid diving while pregnant.
Clear advice. Okay, what about older divers? People wanting to dive into their 60s, 70s, beyond. Specific concerns.
Yes, definitely. Age brings physiological changes that can make diving riskier or more challenging. Cardiovascular changes are a big one.
Like what?
Blood pressure often increases, peripheral resistance goes up. Maximum oxygen uptake and work capacity tend to decrease. Heart function changes, maybe increased preload, decreased contractility, lower max heart rate.
And cardiac issues are already a leading cause of diving deaths.
Exactly, especially over 40. Diving puts stress on the heart. Exertion from swimming, increased preload from immersion shifting blood centrally, increased afterload from cold water vasoconstriction. So cardiac risk assessment is vital for older divers, maybe stress testing if they have risk factors.
What about the lungs?
Lung function also declines after peaking in our 20s. The chest wall changes, diaphragm might fatigue more easily, elastic fibers degenerate, leading to decreased compliance, air trapping, kind of like age-related emphysema.
Affects breathing efficiency.
Yes. Immune function in the lungs might change too. Bronchial reactivity can increase stronger reactions to irritants. Dead space increases, vital capacity decreases. Combine that with reduced cardiac response and muscle mass, and overall exercise capacity drops. And importantly, the lungs' response to low oxygen or high CO2 might become less sensitive, increasing risk.
Metabolic issues. diabetes.
Higher risk of hyperglycemia. Also, potentially reduced awareness of hypoglycemia, which is dangerous underwater and could mask DCS symptoms.
Other age-related risks.
More susceptible to hypothermia, maybe thyroid issues, reduced cold sensation, meds, less fat. Osteoporosis can limit function. Eardrums might be weaker, higher risk of rupture.
So no absolute age limit, but a very thorough medical check and risk assessment is needed for anyone over 40.
Absolutely. It's about individual physiology and fitness, not just the number of birthdays.
Makes sense. Okay, what about long-term effects? Things that might show up years later from a diving career.
Two main ones are well documented, mostly in commercial or career divers with lots of deep or long dives. Dysbaric osteonecrosis, or DAWN, in hearing loss.
Dawn bone death.
Vascular necrosis, yeah. Bone tissue destruction, usually in long bones, hips, shoulders, not typically seen in recreational divers. The thinking is it's caused by asymptomatic bubbles, maybe direct pressure effects, damaging blood supply to the bone.
Risk factors.
A number of lifetime DAPTs over 115, 130 feet. Older decompression methods, also previous DCS, age, heavy drinking, smoking, high cholesterol. Saturation diving seems to increase risk.
The symptoms. Treatment.
Arthritis-like pain. NSAs for relief. If it's near a joint or getting worse on scans, it can disqualify you from diving. Joint replacement might be needed eventually.
Then the hearing loss.
Usually high-frequency sensorineural loss, likely from repeated ear barotrauma, maybe inner ear DCS, or both combined. Regular hearing checks are a good idea for frequent divers. Significant hearing loss from a dive injury might mean stopping diving, especially if it's one-sided.
And diving after ear surgery.
Generally discouraged. Risk of damaging the repair, causing more hearing loss, needs very careful ENT assessment, if unavoidable.
Sobering long-term possibilities for those pushing the limits. Let's talk medications. Lots of people take meds daily. How does that interact with diving?
Crucial topic. Any medication, prescription, or over-the-counter changes your body's state. Some can definitely increase diving risks.
Which ones are most concerning?
Anything impairing physical or mental ability, decision-making. Alcohol is a definite no-go. Same for sedating meds or anything altering mental state. Think about interaction with nitrogen narcosis. Meds that prolong the QT interval on an ECG are risky due to arrhythmia potential. Even badly managed blood pressure meds can be dangerous.
What about common OTC stuff people might take to enable diving? Colds, motion sickness, pain?
Yeah, important to understand those too. Antihistamines for allergies, colds, motion sickness.
Benadryl, Dramamine.
Things like that. They block histamine, but side effects can include dry mouth, blurred vision, drowsiness, sedation, all bad for diving alertness. Some can even affect heart rhythm.
Decongestants for clearing ears.
Like pseudoephedrine. They work by constricting blood vessels in the nasal passages. Helps with equalization, maybe, but they also stimulate the heart, raise blood pressure. Side effects can include headache, nausea, hypertension, rapid heart rate, dizziness, agitation, contraindicated for divers with hypertension or heart disease.
Anti-motion sickness drugs, scopolamine patches, meclizine.
Used a lot for boat rides. But drowsiness, fatigue, even respiratory depression are common side effects. They can seriously impair the alertness and coordination needed for safe diving. Increased risk.
Painkillers. Anti-inflammatories like ibuprofen.
Taking them for aches might let you dive, but the underlying problem is still there, could worsen. And crucially, pain relief might mask mild DCS symptoms, delaying vital treatment. Plus, NSAIDs can cause stomach issues, heartburn, ulcers. Need careful risk-benefit thought there.
Really makes you think twice about popping a pill just to get in the water. Okay, back to the environment itself. What other hazards are lurking down there?
Plenty. Beyond the physiological stuff, just being underwater has risks. Awareness of surroundings is key. Boat traffic, overhead propellers, anchors.
Dive flags are essential.
Absolutely. Use surface markers. Depending on where you dive, especially commercial military work, there could be environmental toxins, infectious agents need protective gear. Marine life, know the local risks, what bites or stings, and how to treat it.
What about less common but serious hazards, explosions?
A real danger for military EOD techs, underwater welders maybe. Water transmits blast waves incredibly effectively, causes spalling shearing damage at air-water interfaces in the body. Lungs, ears, sinuses, gut.
Blast lung, bowel injury.
Serious trauma. Needs advanced life support, trauma center. Electrocution is a risk with powered equipment, underwater burns, arrhythmias. High-intensity sound sonar explosions can cause permanent hearing damage, and military divers near reactors might face radiation exposure, though that's tightly controlled.
A minefield of potential issues. Let's circle back to human factors. You said human error is common.
Very common. Diving demands good physiological reliability, stamina, fitness to dive. Basic physical fitness is crucial. It's demanding work, needs constant assessment. Proper training on gear in emergencies is non-negotiable.
What about innate responses, the diving reflex?
Yeah, that reflex slow heart rate, peripheral vasoconstriction helps conserve oxygen. But it's also implicated in some drowning incidents, arrhythmias, especially with conditions like long QT syndrome, maybe even strokes due to blood pressure changes, can be dangerous if you have predisposing conditions.
Hypothermia. Always a risk in water.
Always. Water sucks heat away fast. Need proper protection, even in tropics, especially with helium mixes. Helium conducts heat even better than air. Treatment is controlled rewarming, life support monitoring.
Hyperthermia. Getting too hot.
Can happen, especially in warm water with high exertion. Heat edema, cramps, fainting, exhaustion, heat stroke. Complications like electrolyte problems, muscle breakdown, kidney injury. Need to cool down, supportive care.
Other human factors.
Lack of experience, panic, getting disoriented, poor training, equipment failure due to misuse or bad maintenance. All contribute to accidents.
So being prepared physically, mentally, technically trained, and having well-maintained gear are all paramount.
Okay, one more specific environment. Altitude diving. Lakes high in the mountains. How does that change things? Big difference is the lower atmospheric pressure at altitude. This changes the pressure dynamics compared to sea level
Affects dive planning.
significantly. A dive to, say, 60 feet in a lake at 5,000 feet altitude is physiologically equivalent to a much deeper dive at sea level around 72 feet. This reduces your allowable bottom time, according to standard sea level tables.
So you need special calculations.
Yes, methods like the Haldane method or cross-correction convert altitude depth to an equivalent sea level depth for table use. The U.S. Navy has specific guidelines about when adjustments are needed based on altitude and depth.
What about just arriving at altitude? Need to wait before diving?
Yes, that's calibration. Your body needs time to off-gas nitrogen to equilibrate with the lower pressure. Recommended 12 hours usually. If you dive sooner, you need special calculations accounting for that residual nitrogen.
And altitude sickness itself.
That's acclimation, the body adjusting to lower oxygen. Acute altitude illness, AAI, can happen above 6,500 feet or so. Ranges from acute mountain sickness, AMS, headache, nausea, fatigue.
Like a bad hangover.
Pretty much. To high-altitude cerebral edema, HACE, AMS plus confusion, ataxia, potentially coma, and high-altitude pulmonary edema, HAPE, fluid in the lungs, cough, shortness of breath, very dangerous.
Treatment for altitude sickness.
Descent is the only real cure. Oxygen helps. Meds like acetazolamide can prevent or treat AMS, but HACE and HAPE need immediate descent and oxygen. You definitely don't want to be diving if you have significant altitude illness symptoms.
Complex interactions there. Okay, related topic. Flying after diving. Very common for traveling divers. What are the guidelines? Is there a simple rule?
Unfortunately, no single simple rule. Recommendations vary. It depends on your dives, depth, time, number of dives, decompression stops, your personal health, fitness, any DCS history.
So what do organizations recommend?
The U.S. Navy uses repetitive group designators based on your diving profile, and the planned flight altitude to give a required surface interval could be hours to 24 hours. Commercial cabins are pressurized to about 8,000 feet equivalent. They ended a key study simulating dives, then flights in a chamber. After a 60-foot, 55-minute dive, flying after only 3 hours gave a significant DCS risk, maybe 10% definite DCS. 6 and 9 hours weren't much better statistically, but waiting 12 hours dropped the definite DCS risk way down to around 1%.
So 12 hours seems like a reasonable minimum for simple dives.
That's often the guideline from Dan and the Undersea and Hyperbaric Medical Society, UHMS, for single no decompression dives. Longer intervals, 18, 24 hours or more, are recommended after multiple dives, multi-day diving, or dives requiring decompression stops.
Are there exceptions or special cases?
Military might have shorter intervals with precautions like breathing oxygen during ascent in the plane. Different gas mixes have different rules. Heliox might need 12-24 hours. Saturation diving needs at least 72 hours. Pure oxygen rebreather dives with no nitrogen loading theoretically allow immediate flying.
But ultimately, it's the diver's judgment call.
Within the guidelines, yes. Zero risk means no diving or no flying. You have to use your best judgment based on your health, your specific dives, and the current recommendations. Better safe than sorry.
Absolutely. Okay, final specific area, saturation diving. Sounds extreme.
It is. Sat diving.
Hmm.
Divers live under pressure for days or weeks until their tissues are fully saturated with the inert gas in their breathing mix. After that point, staying longer at depth doesn't increase the decompression time needed.
Used for.
Military, commercial offshore oil gas, deep salvage, and scientific work requiring long bottom times at significant depth. First done intentionally back in 1938.
What's the process like?
3 phases. Compression, done slowly to avoid HPNS and compression arthralgia, joint pain. Time at storage depth. Living in a pressurized habitat, commuting to the worksite in a diving bell or PTC. Then decompression. Very long, days, potentially, depending on depth. Emergency aborts barely shorten it.
Sounds isolating. And risky. Medical help far away.
Very isolated. Medical help can be days away at depth. It really pushes physiological limits. Diver selection is extremely rigorous, need to be physically and mentally tough.
What are the unique medical issues in sat diving?
HPNS, as we discussed, managed by slow compression, gas mix tweaks. Compression arthralgia, joint pain during compression, usually improves with time at depth. Skin infections, fungal, bacterial are common in the warm, humid habitat. Minor cuts need aggressive treatment. Swimmer's ear, otitis externa, it's very common. Prophylactic drops used. Hypothermia is a constant threat due to helium's thermal conductivity, needs active heating of chambers, gas, suits. Gas mix monitoring is critical. Small percentage changes mean huge partial pressure shifts at depth. And DCS can still happen, often. Type 1 leg pain during decompression. Treatment follows standard principles.
An incredible feat of engineering and human endurance. Well, we have covered a vast territory in this deep dive into diving medicine. What's the big picture takeaway for everyone listening?
I think the main message is, diving is amazing, it's enjoyable, but it comes with inherent risks, both from the environment and from how our bodies react to being underwater, breathing gas under pressure.
So awareness is key.
Absolutely. Divers and the doctors who look after them need to be informed about individual risk factors and the specific hazards of diving. Every single dive needs a risk assessment. Plan it, discuss it, account for the risks before getting in the water.
But with care, it's manageable.
Definitely, with the right precautions, training, equipment, and judgment, diving is a relatively safe and incredibly rewarding activity.
Absolutely. We've really gone from the basic physics governing it all, through the physiological challenges, the potential injuries, the gear, special populations. For you listening, seeking that quick yet thorough understanding, I hope this journey beneath the surface has sparked some aha moments about pressure, gas, and the amazing human body.
And remember, this field is always evolving. Research continues. There's always more to learn if you're interested.
And a final thought to leave you with. Considering all these complex responses, all these potential dangers we've discussed, what does our relentless drive to explore this fundamentally hostile environment really tell us about human resilience, our ingenuity, and maybe just our sheer curiosity? Thanks for joining us for this deep dive.